Welcome, welcome, welcome. Because we often see people trickle in after a few minutes, so maybe before we dive into the topic of today, can you, Graham, maybe talk about some of the books that you have gifted or recommended most to some people in your circle?
Sure. I just finished Legacy by Dr. Uche Blackstock. Uche was a fellow in ultrasound when I was in residency, so I know her personally, and it's a really great story about um, a, it's both a story about the power and the strength of her mother and the loss of her mother, and Uche finding her own way, um, and trying to really change medicine for the better around race and minority groups. And it's a fantastic book, highly recommended. I also just finished Marty McCary's the Price We Pay. I had read his prior book, and I just finished that one as well. I'm going to try to do write some book reviews on both of those, and then my totally out there fiction escapism is this book series called Dungeon Crawler Carl. It's kind of sci-fi fantasy about this guy who the Earth gets taken over by aliens, and he has to fight his way through a dungeon with his ex-girlfriend's cat, who's named Princess Donut. And I've I list the audiobooks are incredible. I highly recommend Dungeon Crawler Carl in the audiobook series. And like the seventh book is dropping next week. And so I'm like re-listening to all the audiobooks. It's like my guilty pleasure.
Very
I
nice and
loved the
well
price we
noted.
pay. It's an amazing view into the US health system, but it also made me very cynical. At the end, I was like, okay,
Yeah.
this is never gonna change.
Yeah, the last third in particular is like, I think a lot of physicians know some of the stuff he talks about and contracts and how the system has a lot of perverse incentives. But the last third in particular, there's a bunch of stuff I learned. And I'm a policy guy, so it was really interesting to see all the levels of like just middlemen in the system. I mean, that's probably the biggest takeaway is like there's so many middlemen in the system that are all taking their piece.
Yeah, well, I'm really curious because it's part of the administration now, so let's see what's gonna change in the next 4 years.
Well, yeah, I breaking news: RFK Jr. just uh, got confirmed by the U.S. Senate as Health and Human Services Secretary, just as of I think like 10 minutes ago. And then yeah, Dr. McCary's been nominated for FDA, which I think he'll have to go through. I think he has to go through the process as well. I don't think that's appointed by the president. So yeah, we'll see. Interesting times to say the least.
We suddenly became a news podcast as well, which is very
That's
cool.
right.
Thank you for sharing that.
Breaking news.
All right, but let's also dive into the topic of today, which is how to win over care teams when you roll out AI. And obviously, you, Graham, you have been doing and thinking about that for a very long time. So maybe before we dive into the topic, can you briefly explain your background and your experience doing that?
Yes, I'm both a care team and trying to convince other care teams as well. Yeah, so my name is Graham Walker. I'm an emergency physician here in San Francisco, California, where it is currently raining and overcast. And I have several roles. One of my roles is my primary role is an ER doctor. So I practice, um, days, nights, weekends, holidays, caring for patients. I work for the Permanente Medical Group, which is the medical group, the doctor arm of Kaiser Permanente here for Northern California. My other role in KP is also in charge of what we call advanced development. So we are looking, one or two steps ahead of everything in terms of what technology is coming, really from the technology industry, and what could we use within our organization to deliver better care for our patients, to make our care teams more efficient and adopt new technology. So we're not deploying stuff into production. That's what our technology team does. My role is kind of one step more innovative and more out there in terms of just seeing what's coming down the pipeline. My other roles in life, I created a website and an app and a company called MdCalc. MdCalc is used by about 70% of U.S. doctors every month, and many doctors across the world, to answer clinical questions when you're kind of seeing a patient and you're trying to figure out how to manage a particular patient. We use scores from the published literature and kind of digitize those and add in additional information to help support clinicians caring for patients. Or an app and a website and everything like that. And then just recently, I founded another company called Offcall, offcall.com. And we're really trying to improve the fairness and the transparency around physician pay and physician workload, as we've seen a massive shift in the past decade, the past 10 years. Physicians in the United States are mostly employees of someone else now. So that's been a dramatic shift. Just 10 years ago, we were mostly running our own small businesses, running our own medical groups, our own practices, and now we're employees often of health systems, sometimes of private equity groups as well. And that's created a lot of new tension and friction that we're hoping Offcall can address as well.
Very impressive and good explanation why you are here. All right, I think we can start. Maybe Thomas, I think you had a question that you wanted to ask first, right?
Yeah, absolutely. Or maybe Rick, for the one person in the audience that doesn't know you or me yet.
Oh yeah, that's smart.
Want to
Yeah,
give a
so
quick personal intro?
Rick, RN by training, now currently product lead at Sort Health, so I'm deploying a lot of AI stuff as well to PTs particularly.
Yeah, I'm Thomas, co-founder of AWell, which is the CareOps orchestration platform, also co-author at CareOps together with Rick. Great to see you all. Graham, so AI in itself is a very broad category, right? And we're starting to see subcategory solutions coming up. Okay, can you list what these 3 to 5 main AI categories are that you're having on your radar today?
Sure. There's a couple different ways that my brain kind of does Venn diagrams of everything. The largest one, because I'm all focused on medicine and healthcare, of course, is predictive versus generative. That's my biggest breakdown. There's probably some like overlap, like there's like a third circle in the Venn diagram. There's also like maybe multimodal is somewhere in the middle that generative, I think right now we're obviously mostly thinking about text, but we're starting to see multimodal models. But there's probably some overlap with predictive AI. If you were to show, a chest X-ray to a generative system and a predictive system, there's maybe some overlap there. But those are probably the two big camps that I think about in terms of kind of technical classification. And then when I think about kind of use case or medical or healthcare classification, I probably think of it as, one would be kind of back office, administrative, paperwork type stuff that has very little to do with patient care or care delivery. There's a lot of gray zone there, but you could probably the most obvious example would be prior authorization stuff, billing stuff, is mostly not really related to the actual doctor-patient relationship. And then there's a piece that's, helping the healthcare professional, whether that's a PT, whether that's a physician, whether that's a pharmacist, that is kind of helping us with our internal work that's maybe not exactly patient facing. So for me, it might be coming up with a differential diagnosis or coming up with a management plan, right? That is physician work that exists in my head right now, and that maybe an AI tool could help me with, but it's not something that I'm necessarily involving the patient in directly. And then there's another piece that is mostly or almost exclusively patient facing. So, a chatbot that could maybe take some history or can give some, maybe nursing level or even eventually physician level guidance or recommendations. And then there's probably a piece that is kind of supporting the doctor-patient relationship. So that's probably things like maybe AI scribes. That's tools that are helping with shared decision-making for physicians. So that's probably And then, I'm sure there's many, many, many other tools, but those are probably the broader categories where I see myself interacting with AI in certain ways in my role as a physician.
And so when you have those tools, I think technology is one side, but like implementing it is another side. And in
Totally.
my opinion, like trust is probably the biggest barrier right now to get to AI adoption in healthcare. So can you like maybe explain to the audience like what are some of the reasons that care teams don't trust AI at this point?
Sure. I think you're right, Rick. The tech work is work, and so is the implementation work. I think a lot of people think, oh, I'll just, well, the doctor should just start using this. And yeah, it's a lot of work to get the change management and the implementation are really challenging. I agree with you. The trust piece is very important. I think there's several challenges that come to mind around trust. One is this technology still feels very new, especially to doctors. If you think about a new drug or you think about a new imaging modality, most of these have usually been around and go through an entire like life cycle of testing and validation for maybe decades before they actually reach like production level, like interfacing with a doctor and a patient. ChatGPT, I mean, and certainly AI has existed for a very long time, but the modern version of AI, which I think many people would probably say like, started with ChatGPT 3.5 back in November of 2022, right? I mean, that's a very, very recent new development. And so doctors tend to be a particularly conservative group of people in terms of change. And that is both a blessing and a curse. The blessing is we don't want harm to come to our patients. And we know the way that we were trained in residency or the way that we practice medicine today is working. Is it the best way to do things? We don't know. There are not really great studies on is this workflow the best workflow in terms of cost efficiency, safety, whatever. But we know this one works. When I have a patient with rapid atrial fibrillation, the way that I do things, I know it works because I've seen the results of it, and so I continue to use that workflow. But with AI, it's much more nebulous, and so it's the first piece is just trusting that it's going to be safe and work correctly, because you're comparing this new thing versus the thing that I personally know works because I use it every time on my patients. So that's part of the trust piece, and then there's certainly more of the technical trust pieces around bias, around hallucinations on the generative side as well, that I think make us all a bit more hesitant to trust these tools. And then, the other one is just the black box nature of some of these tools. I particularly think that we'll need like a period of time of like, all the AI models that doctors use for 5 or 10 years all have explainability built into them so that doctors can start to understand them, get comfortable with them. The black box piece is a particular challenge because if the answer just says, oh, Rick has a 30% mortality in the next 30 days, that's not actionable to me. I don't know what to do with that information necessarily without the AI telling me why it thinks Rick has a 30% mortality. Now, if Rick, you come into the ER and you're hemorrhaging, you were shot or something, okay, I have a pretty good idea why it's going to say, Rick has a high mortality. But if it's just like, oh yeah, Rick went in for a checkup, he had no symptoms, he was just, and the AI is flashing high risk. Well, I don't know. I don't know what to do about that information. Do I order a lipid panel? Do I tell you not to go on a plane flight? I mean, what do I do? And then B is, I don't know if that information is accurate or not. Doctors are very comfortable assessing data and making decisions about if they should trust or not trust data. We know intrinsically not intrinsically. We know because we've been trained and taught this, but we know the false negative rate of a CT scan is for appendicitis, or the accuracy of a white blood cell count for appendicitis, or the rate that you can have a kidney stone and not have blood in your urine. These are all things that were taught during our training. And so I can make a judgment call when I'm seeing a patient who I'm like very sure has a kidney stone, but they don't have blood in their urine. And I can say, I'm going to reject that urine test. I don't believe it. I still believe this patient has a kidney stone. And because of that, I'm going to order a CAT scan, or I'm going to give you some medicine that I'd use for a kidney stone. When it comes to an AI black box, unless explainability is part of the model, we will not have that information. And so we will still be responsible for the outcome of that patient, but we won't know in which quadrant the AI is falling. Is it a true positive, true negative, false positive, or false negative? And that's the thing that I think that's particularly scary. It's like the level of responsibility to know if we should trust this or not trust this, but not any of the information to help us decide that.
Graham, quick question here. So you talked about medicines and specific evidence-based care that ran through an entire life cycle and then it's proven to work, but there is no such thing as that is 100% effective, right? You talk about
Right.
false negatives, false positives, and so when you talk about bias and hallucinations, to what extent do you think doctors could be comfortable saying, okay, a medicine has side effects, right? And these AI models that I work with are also not a 100% solution. I know that there is a percentage of the time that it will be wrong, and I accept that. It sometimes seems that with AI, people have raised the bar. Then we've been working with through millennia with these things that are not perfect, and now we're expecting something to be perfect.
Yeah.
Do you think they could map that mental model onto AI as well?
That's a great question. I think the challenge is going to be that these AI models are already very, very, very good. I don't know if I'd call them excellent just yet, because there's domains where they're pretty bad, but they're very, very, very good. And I think it's kind of human nature for physicians to eventually stop double checking things. So in some ways, Thomas, I do think these are very similar to any other tool that we might use in medicine, but in some ways they're kind of different. Like I would be okay if a AI tool added something to a differential diagnosis that was incorrect. Say the patient had pain in their ankle and it said appendicitis. Well, intuitively, I'm going to know, oh, that's screwed up. That's recognizable to me as an error. What is less recognizable is like the dosage of a medicine. And so, I would be fine with it screwing up and saying appendicitis for ankle pain. I would be worried if 1 out of 100 or even 1 out of 1,000 times it confidently tells me the dose of vancomycin is, 3 milligrams or something like that. Now, and 3 milligrams actually is not a good example either, because intuitively I actually know 3 milligrams is definitely not right, because vancomycin is usually dosed as grams. So if the AI instead told me, oh, it's 2.5 grams, and I don't prescribe vancomycin very often, that vancomycin does have some problems if you give too much of it, and so that would be an example where I'd be like, oh, I guess it's 2.5. I didn't know that. Oh, I'm gonna go ahead and order 2.5, and then hopefully we've got, with the Swiss cheese model of medical errors, hopefully we've got a pharmacist that's paying attention. It's like, who is this idiot Dr. Walker who's ordering 2.5 grams of Vanco? And so that's the challenge, is that you don't know when these things are incorrect. It's like the unknown is the piece that worries me.
And so on that worry, you mentioned like some of the reasons why clinicians tend to not trust AI in the beginning. Is there like any like practical examples of like how you have built trust with AI? Because you, for example, implemented scribes that guys are like you probably have a lot of learnings on like what is it that will like trigger the thing of like, okay, I'm gonna trust this thing.
There is nothing more powerful to convince a physician of something than a testimonial from another physician. That's a dangerous secret to reveal to the audience, but it's very much true. And so the way that we dipped our toes into the pool of an AI scribe tool is we used it with extremely tech savvy people, and let them, gave them training and education and warnings. Hey, this tool may not be perfect. So that we could get their feedback first and see if they liked it or not. And then we expanded that pilot further. And then once we were like, okay, yeah, we think this is worth the squeeze. This is worth all the training we're gonna have to do to get people on board with this new technology option. One of the ways is we used testimonials. So that can be a really powerful way to get doctors to try something that they wouldn't otherwise try, because you can give doctors graphs and data and charts, but practicing medicine is often a very personal experience, and so we often don't trust trust other people or trust data. But if I heard about a new AI whatever platform and like 10 ER doctors were like, "Oh my God, this thing is amazing. I use this every day. It's so helpful." I would trust that way more than a piece of data that said, "Oh yeah, 90% of ER doctors use this," which I'm realizing is kind of a weird thing to say because doctors are so data driven. Like we use data every day to determine what we do and how we practice. But when it comes to our own, like changing the way we practice, so much of it is personal.
It's maybe because a couple millennia back when we looked at the bush and we tried to understand the data, we would have been killed. Whereas if we would just take the cue from one of our fellow hunters, we lived. So it's probably very ingrained in.
It's like deep in the amygdala, which is like somewhere in here. Yeah,
our
the midbrain.
Yeah, but have we cracked the nut, Graham? Is it like find the early adopters and innovators in your health system, the ones who are always buying the latest iPhone? I'm making a very quick shortcut here, and you try this out with them, make sure that it works. It's never going to work the first time, but obviously do some iteration. That's where CareOps comes in, and then spread it. Is that the silver bullet?
Yes and no. I think it depends on the technology, and you're hitting on a really good point, Thomas. I have found, and I say this openly, I like the AI scribe tools. I don't use them very much personally, me. And I mean, but that's because I'm like a super techno nerd. I mean, if you look at my screen, I've got a bunch of screens set up here in my room, and I've got keyboard shortcuts for literally everything in my life. And in the same way, when I use my EHR, I have spent the time to build a bunch of EHR templates that make it easier for me to get through notes and everything like that. Now, I will start using those tools more when they have additional features like pended orders and helping me with diagnosis and billing, because then it's like now these tools have not just doing notes, which I feel like I'm already fast at notes. So this is a roundabout way to say, Thomas, that some of our biggest users of AI tools and other technology as well are often kind of what people would probably describe themselves as like technophobes. They are not good with technology, and this is a response to helping them with like they're probably like hunt and peck typists. They probably are really slow typing. They may not like to dictate, which is another option that some people have. Dragon, started as a dictation software, and so sometimes you'll see in the AI literature people talking about this concept of like leapfrogging, and so you go from taking somebody that's a technophobe that has trouble getting their notes done on time, and they're spending 3 hours a night at home writing their notes, which is miserable for their quality of life. And then you like enable this AI tool, and now they're actually like the fastest people, they're done at 5:30. And so like, it's the people who were the slowest who are now the most efficient or the fastest when it comes to notes. I mean, there's certainly other technical work that has to get done, reviewing results and responding to messages and stuff like that. But there are certainly a lot of people that have gone from extremely slow to extremely fast, and they've actually leapfrogged over the people that are like, oh, I only spend 30 minutes at home writing notes or whatever. So we intentionally went with the techno file users, the early adopters, to try the thing out, because they're going to not abandon a tool that's imperfect. They're more likely to report bugs. They're more likely to give feedback because they have an intrinsic understanding that this is a pilot, that this is a technology that's not integrated into the EHR, that's not perfect, whatever. But then, and this was something we had to learn. Like, I thought for sure the highest users would be the people that are already tech savvy and that are early adopters, and that has not turned out to be the case necessarily. And there's also, back to my last comment, there's also other pockets of information of departments and groups that have trained each other, and so you have the data often won't look crystal clean because you've got some super passionate person in the Department of Urology in San Jose who loves this tool so much that they have invested the time to teach their entire department how to use the thing. And so now you've got this interesting outlier group. What is your urology? We're not seeing that used anywhere. And it's like, oh, there's just one person who is like a super user and a power user and an educator of this tool. And so then how do you bottle that up and spread it as well?
And so one of the things with AI is also that it's very easy to make very mind-blowing demos that you then can post on social media. It's like, for example, stupid example, I was looking into voice AI, and like on the surface it looks impressive, but if you then take into account that every provider has like specific scheduling rules, like I don't want to see new patients on Monday and Tuesday, I want to do this, we need to do an eligibility check. Like, once you understand how messy healthcare workflow is, the demo breaks. So what are like some of the mistakes health systems make when, for example, buying technology or buying AI one and then also implementing it second?
Rick, I say this to Epic all the time. Their demos and their screenshots are always way too simple. And so that's always my feedback to Epic is, hey, you built this new feature. Great. Oh, this is a cool new feature. Can you please try it out with a patient that has like 37 medical problems and has, is on 40 medicines and has, 30 notes in the past 2 weeks? Because you're absolutely right. That is the demos in healthcare can be really helpful to convey a concept, but then applying them to actual real human beings is another thing entirely. And then I guess the other thing I'll point out about that is, medicine spends most of its time managing patients with chronic disease and chronic illness. Most people who are healthy are not having multiple doctor's appointments. And so the majority of most patients that I see in the emergency department are older patients with lots of comorbidities. They usually have diabetes. They often have heart failure or COPD. And so that makes the demos even worse because most of the time you're not actually, Epic has the thing with, the patient has 3 problems on the problem list. That almost never happens. It's like occasionally I see young, healthy people in the ER, but most of what I see is like really long problem lists and really complex systems. Sorry, I've lost your question entirely, but you just, that demo concept, I was like, oh, I have to say this because it's so true. What was your question about?
Thomas, go ahead. I think.
Yeah, no, I have a follow-up question. So
sure.
Indeed, the demos obviously very often show how it works for a simple use case, but that's not healthcare. Another part I think is that a demo and definitely a pilot is not a true embedding in the workflow, right? So many of the AI tools, they need the relevant context. then they capture some data, and then where is that data going? Does it become a task for the care team? Does it get written back into the HR? In what way? How does it drive subsequent actions further down the line in the care flow? And so could you maybe talk through some of those challenges? Maybe they're both, technical, but they're also challenges around understanding where it fits and how it hands over to humans, whether that human is a patient, whether that human is a care team, and how you can address those kind of challenges.
Yeah, the integration piece is a challenge. Getting back to Rick's comment about trust. I mean, the other piece of trust is just like the trust and security of the data. So that makes integrations all the more challenging as well. Every hospital is going to, I mean, this is the reason hospitals are sometimes, challenging partners to work with. Every hospital is going to want you to have gone through your own, SOC 2 compliance and, have the BAA and ask you 100 questions because it's their responsibility to make sure that your data is safe. And so it is much easier to do like a freestanding pilot or even a full deployment that is not integrated. And so I think that's one of the reasons that AI scribes have been probably like the biggest AI use case in healthcare is you can kind of separate them out from everything else. Like, would it be nice for the AI scribe to know the patient's past medical history and the meds and allergies and stuff like that to make the note even better? Yeah, sure. But you still can see a patient without integrating it into the EHR. Versus, there's other tools like the reason I think predictive AI is slow to take off is predictive AI needs a ton of data and it needs, and that's just always going to take longer to get a health system to agree to share that data, figure out how it's going to be used, all the business case as well. And then, Thomas, to your point on like getting the stuff back into the one system of record, right? Because you don't want to have two competing systems. That's like a fundamental clinical informatics thing. There needs to be one source of truth somewhere. Most people, at least in the AI scribe example, have found the like less integrated. Okay, I need to copy and paste this into my EHR from a web browser or an iPhone app or whatever. Most people have found that to be an acceptable trade-off because there is so much value in having their note already written. So they are more than happy to click copy and then paste the note into the EHR and have to then also skim the note and edit it, make sure it's accurate, and then also like put in the orders themselves. So maybe they discussed with the patient, oh, we're going to get a right ankle X-ray, and they're like, okay, yeah, it would be nice if the tool could have pended that ankle X-ray order, but because it saved me time writing my note, which not only takes up time but is like laborious, and doctors hate writing notes, they find that acceptable. But it's also always a growth mindset. I mean, I think that's probably the challenge for a lot of the AI scribe companies is, the doctors say, "Oh, this is great, and can you add these 50 features?" So it's finding that balance of like, okay, is this an acceptable enough product to put in the hands of doctors? And then, I mean, doctors always have lots of ideas of what we think is an important feature and what's not, and why we're right and the other doctor's wrong. And, I mean, that's just the personality of medicine too.
And how does this change if it's a patient-facing use case? So we're talking a lot about AI scribes, but let's say you have a conversational AI agent calling your patients post-discharge. It will collect some data from those patients. Have your symptoms worsened? Have you picked up your meds? Have you scheduled your visit with the PCP? That all of the answers to those questions will actually trigger downstream activities, either for the care team, for the patient, for the PCP, might trigger alerts. And so it's much less, feasible to run those kinds of solutions in a standalone way, as you just described with an AI scribe.
Yeah, you're absolutely right. Those are both, it's like the trade-off. It's like small and scrappy versus like integrated and powerful. Like stuff that is that's patient facing is going to have to integrate with the EHR and the rest of the system in order to, if you want to have any automation and any trigger events. Like the reason it works out in AI scribes is because, well, you got a human user that has access to the secured access to the EHR and can, use it the way they want to. If you have patient facing stuff, it's like you said, it's going to have to integrate in some way. Now you could imagine, like, you could have a somewhat separate system for home visits or something, right, or patient level information, and then the EHR does the work, or some some cron job or some script like pulls that data into the EHR manually. um, that could work, right? You could have an AI bot calling the patient, and oh, the patient reports they have a fever after their appendectomy or something like that. You could certainly have a separate system that is then calling the doctor, or getting messaging the physician, and then the physician is going to be the one that orders the additional test, or documents that the patient reported a fever. So there are some workarounds, but of course that's going to be something that people are going to say, oh yeah, this is temporarily okay. But could we also get rid of that call to the doctor? What if it was all integrated? And that would be the ultimate solution, but it's also going to take a lot more development time and a lot more investment from both parties to, like, build out those connections too.
That sounds a lot like how health systems have been procuring point solutions in the last 20 years that were not
Yeah.
AI solutions. So what is making this time around different? Or are you skeptical, and are we headed for another ecosystem of point solutions that are not integrated because there was just not enough incentive to do it? This time around, it's just AI point solutions.
I think things are a little bit different in that, Epic Epic and all the EHRs are a little bit more open. I think are aware of, like, the changes that are happening in American healthcare, where people want access to their data. Where, you guys know this, like, Epic never, ever, ever partnered with anybody. That's like one of their 10 commandments, is like, don't partner, don't acquire, just build it yourself. Well, now they have, like, a Nuance partnership and an Abridge partnership, and like they have, like, they're setting up a platform for payers. So I think even Epic, which is extremely insular and extremely closed, and they have an app store, like, they prefer not to let anybody do anything. I think even Epic is starting to realize they're going to have to play well with others. And so I don't know, Thomas, I think it could go either way. It could be um, that it gets much easier to integrate. Um, you know, there's some standardized integration approach, and or like, way to make sure that the data is doesn't leak anywhere and doesn't go anywhere. Or it could be that we just end up with a bunch more point solutions, um, because the world's moving so quickly that the integration is not viewed as valuable. I don't know.
And so to throw it to like a totally different direction, whenever I talk to technology leaders or like people doing implementations at health systems on AI, they always say like, you need to involve the doctor, you need to involve the doctor. But like, how do you do that practically? Because you are like 100% practicing. You don't have time to like provide feedback on buggy systems. So like, how do you involve them, and then how do you incentivize them to actually use the thing or provide feedback, and any learnings there?
Yeah, lots of learnings. You're absolutely right. Doctors are um, we're both busy and we're really expensive. And so, from the health system's perspective, um, or the employer, or whatever, or just the doctor themselves, like, the doctor is creating a lot of value, and is and like, because we're highly compensated as well. The health system doesn't want to have a doctor spending their time not seeing patients if they can. And so I think, part of being a good partner, um, as a hospital or as if you want to integrate an AI solution, is acknowledging like, hey, if we want this to go well and be really successful, we need to acknowledge that that's going to require some physician time as well. I think uh, I think it is silly to say, oh well, we need to involve the doctors, but then not acknowledge that that's going to take time, and that's going to be an investment that the health system is going to have to use. Like, you can imagine any AI partnership, integration, vendor relationship, everyone else is getting paid for that relationship. And so I think that's one of the things that often feels a little bit silly is well, the doctors should be doing this for free, but everyone else, the administrator, the IT people, the vendor, whoever, everybody's getting paid, but the doctor should be giving up their time for free for this because it helps them in some way, So um, I think you have to a good health system partner will acknowledge that. Like in my own organization, we have department technology leaders who are given some time to teach and educate about IT. And that time, kind of counts against the number of hours that they're expected to be seeing patients as well. Um, it is really hard to get feedback from doctors, even bug reports, like you mentioned. If you can go in person and just be a fly on the wall and just watch what the doctors are doing, and or just be there to help answer questions. I find that to be extremely helpful, and you will learn so much more than you would ever learn by just doing a bug report on how doctors are trying to use your tool either successfully or unsuccessfully or in ways that you did not expect. I think that's one of the things that Epic does really well. Epic will send out they'll like fly out a team of like 5 developers. If they're working on a new feature or they want feedback on how to make a particular feature or better, a product better, they'll fly them out and they'll spend a couple days at an institution and just be a fly on the wall and just, they're just physically there and physically available so that if the doctor has a question or the doctor has a free moment, the Epic person can ask them, oh, well, hey, can you show me how you did that, or why you did it in that particular way? I think that level of like on the ground support, I think, is tremendously valuable for the physician and the health system, and certainly for Epic as well, to truly understand what are they doing, why are they doing it that way, or why are they requesting this feature and not that one. That's how you can really, like, again, doctors, we all think we're right. We think we all think we're super smart, and so we love it when someone cares about our opinion about something. So.
As part of this involving clinicians early, do you see at KP or is there a goal to combine these clinicians with tech people, with other stakeholders, or is it more of a separated activity?
When we have a formal like partnership and contract and agreement, yeah, we have close interactions between the company or the vendor and the doctors. If anything, because we're such a large health system, we sometimes have to filter how much information we send to the vendor. I was telling somebody like a month ago or something, like we're 10,000 doctors. We have, I think, several thousand non-physician practitioners, NPs and PAs. We have hundreds of thousands of nurses. We have medical assistants. And so you could imagine if we deployed an AI scribe tool and everybody wanted to give their opinion on it or report a bug, no, probably almost no company could keep up with that amount of feedback, right? If there's like 10,000 doctors and in a regular day they're going to see what is that, like maybe 50 or 100,000 patient encounters, and your tool has a bug like 1% of the time. that's still like, oh, 5,000 bug reports a day. Like, oh, no, 500, but still, like, you're kind of hosed. Like, if you're trying to keep up with 500 crashlytics reports on your iPhone app or something like that, you're done. So, like, that's the other, like, scale and sizing thing is, a smaller company is obviously going to be able to get better feedback from a smaller hospital or a smaller health system or a smaller medical group or something like that. Because when you get to particular size and scope of health systems, and American health systems are certainly love to consolidate, like, it probably could become rapidly overwhelming um, an AI partner as well.
And so on the overwhelming side, so also a lesson learned when I was at AWOL, but also when I was a nurse, is like the more doctors that you involve, the slower the progress, because every doctor has like a strong opinion and a strong ego, so they don't want to like deviate from their opinion. And so when you do that implementation, let's say, for example, let's say we have something not AI script related, but like something patient facing, and there's like a feedback loop to the provider, and we want to implement this, like you decided to buy the technology, we're now going into implementation. Like, what does like the meeting structure look like? Or like, who is involved? How do you decide who is involved? Like, yeah, can you spill some beans there?
Sure. It's going to be all of your kind of clinical technology leaders. So your CMIO or CIO, CTO, however your organization defines that. And I would hope that that person has their, like, ear to the ground, finger on the pulse of what their frontline physicians are saying is a priority. And then obviously, they're also obviously getting the feedback from their executive team about what the goals are of this, what the key deliverables are, what the key objectives are for this pilot, or what the goals are for the organization for the year, 5 years, or whatever, and how are you going to merge all of that together? So that's certainly all leadership. And then, Rick, I'll add a little nuance to what you said. I totally agree with you. The more doctors you get into a thing, we're all going to have a bunch of varied opinions, and we all think we're right. We've all got egos. The one piece I'll add, and it took me a long time to like figure this out, is the other problem is we lump doctors all in one group as like, oh, doctors. And yeah, we all went to med school, but we all went to different residencies. Like, what I do and what a pathologist does on a daily basis, we are both physicians, could not be more different. I mostly think, I mean, I think pathologists like look at slides all day. I don't know. And then similarly, like, what we care about is really different. I mean, there's like the stereotypical joke about cardiology versus nephrology. Cardiology usually wants to get rid of fluid, and nephrology wants to give fluid. But we fundamentally, doctors in one large group are going to have different priorities because we do different stuff. Like, an eye doctor, an ophthalmologist is going to care, is going to say, well, the eye drops should be at the top of the list, of course, of the meds. Those are the most important things. The cardiologist is going to say, who cares about eye drops? Put that at the bottom. I could care less about eye drops. So that's the other challenge is, as you, and that's why I've seen some startups try to focus on one specialty as well, because you're going to go deeper into that specialty, provide a perfect solution for emergency medicine. But then the new challenge is, okay, I want to expand to hospitalists that are kind of similar to emergency medicine, but it's kind of different too. You're going to then struggle because now you're not going to have features that hospitalists want because you built so many for ER. It's the same challenge that Epic has. I mean, I have the same criticism for Epic. Epic doesn't build a tool that's perfect for ER doctors because they want a tool that also works for GI and for cardiology and for pediatrics and all these other things too.
There are only two ways to earn money in software. It's either bundling or unbundling.
Yeah.
Maybe that's a good segue into, how do you get a pilot at your organization to actually scale? What are some of the learnings? Like, some stuff gets stuck in pilot eternally.
Yeah.
Other things do scale. What are the patterns that you can extract from your experience?
So I think leadership is particularly important. That this is that this is a priority. And having, I mean, I think our organization has a very smart structure where we have um, leadership at each of our medical centers, and we also have leadership for each of our specialties because those are not exactly obviously the same thing. And so the other thing I've learned is you cannot over communicate something to physicians. Again, we're all super busy people. People don't always read their email. They don't always look at their Epic secure chat messages. They don't always read their Teams messages. I mean, there's like 1,000 ways you can communicate with people these days. And so you can't over communicate things enough. And then really having a having a physician in each department that can understand how this technology is going to help my people, my specialty, is particularly important. I used to be our local KP San Francisco kind of IT kind of tech operations leader, and I fully admitted, like, hey, if we were adding a new Epic feature or adding a new app to people's iPhones, I would like tell all of our technology leaders in every department, hey, I'll give you the slides on how I think you could use this and what it does and how to log in and everything like that. But you guys have to customize this for your specialty. Like, I have no idea what a general surgeon does. I don't actually even know what their screens look like most of the time in their EHR. I don't, I know they see patients in the clinic. I know they have days where they operate. I know they have days where they're on call and they do emergency operations as well. But I'm an ER doctor. I can't know how to book a case for the OR. I can't know how to do post-op orders. And so you have to have people in each specialty that are going to have the time to dive into this tool, play around with it, and be like, okay, so I think actually I could use this for like post-op care, or I could use this for writing my H&P, because all of our work is often so different that we, you know, even if my medical group paid me to just understand every workflow and not see patients at all, I still wouldn't be able to do it. I mean, we have like 35 specialties just at my med center. I was down at Stanford last month. Stanford, I think they said they had 60 specialties. Like, there's no way any one person can keep up with all of that level of detail and nuance that doctors do every day.
And so maybe last question on my side, because you only have 6 minutes. So whenever a technology company, let's say an AI company, goes into an hospital, you have obviously you and like finding the clinical champions, but they often also come with like an implementation playbook. Like sometimes they send you like
Sure.
20 pages on how to use the technology. Sometimes they do a webinar.
Oh, yeah.
Sometimes they
Yeah,
do
yeah.
something else. Like, what is some of the like top 3 things that you've seen like, damn, this was like really, really high bar, really, really good. I would love that every vendor does this as of tomorrow.
I think a video, I think a combo like PDF handout and an accompanying kind of like video screen share showing the tool being used are particularly helpful. Like, I would build those sometimes when they weren't available. I just like record myself and send them out myself. Partially because some people learn differently. Some people want one step at a time instructions and they look at a PDF or even print it out or whatever. And then other people want an actual video seeing the tool in action. But a video is going to like require 5 or 10 minutes of your time to actually watch versus a handout you can do at your own pace. So those, I think having both of those options is what I would pretty much always try to offer to people, because you never know when someone's getting your email, if they're like actually seeing patients in the ER and they're also like trying to multitask and look at their email briefly. And so they do not have time for a 10-minute video, but they can like skim through a handout really quickly and flag it and save it to look at it later. And then there's other people that are like, I the handout is too static, and I want to dynamically see what the heck this thing does. And maybe they play it at 2 or 3x speed, or they skip around. They don't really care to see the 30-second introduction on who the person is that's giving the thing. They just want to jump to the meat of it. So.
Cool. I have an interesting question from the audience, which might be good for the last couple of minutes.
Sure.
So this whole conversation revolved around, assumption that there is buy-in from the organization and we need to get trust from the clinicians. But some people in the audience have the inverse problem. Clinicians are bought in, they want to experiment with AI, but they're being blocked by compliance that says, no AI is entering this organization. What is like a quick fire answer how to work with your compliance to get them to experiment with AI?
I got it. This is going to solve all these problems immediately. I think that the challenge that some health systems experience is not acknowledging the problems with the status quo, and or that there are risks to not taking action as well. So I fully agree that I think generally like compliance and risk and stuff, they are supposed to say no. That's their job. And so I guess the two things I would say is, one, that's going to come from leadership. You need leaders who are going to push and acknowledge that there is risk and compliance to doing AI or doing a partnership. And we shouldn't discount that. And we need the AI tool to be heavily vetted and tested and validated before we use it. Got it. But the leader needs to be able to say, I understand that risk. I accept that risk. And even still, I'm gonna say we should go ahead and use this tool or use this platform or give it a try, because there are downsides to not taking action as well, right? So I don't think anybody would say the status quo of healthcare in America is like killing it, is like super amazing. And so I think you have to consider the risk of not not changing things and just continuing to do things the way they are.
The one thing that I would disagree with is that the US healthcare is killing it, but it's like literally killing it. So,
well, I was going to say that too when I said it, Rick. Yeah. Yeah.
Yeah. We have 2 minutes left, and I want to give those 2 minutes to you. Like, any way the audience can be helpful, where can they find you? Any plugs that you want to do?
Gosh. Yeah, I spend a lot of time talking on LinkedIn. I love just talking and thinking about this stuff, the intersection of technology, which often, but not always, is AI, and then just medicine and the practice of medicine. I think it's a particularly exciting time to be in this space. It used to be that like you really needed to be a doctor or a healthcare professional to get in and have an impact with patients, and I think that's changing. I think technology is really exciting. I see a ton of opportunity. The deeper into this stuff I get, I see a ton more opportunity and way less fear than I used to have. We put out a thing called the Physician's Charter for Responsible AI. I think we need as many people talking about what they would want from a AI system, whether you're a patient or you're a doctor or you're a technologist. Like, how would you want the world to work if you had the power of AI to help you? And I think as more people are sharing and talking about this stuff, that's how things will get shaped and framed. Is the best ideas hopefully will rise to the top, and the best information will get out there, and then the technology teams can go build them.
Awesome. Thank you so much for your time. And yeah, I learned a lot. So thank you for sharing the wisdom as well.
Thanks, guys. Thanks for having me. Thanks to the audience for the great questions. Yeah, feel free to DM me on LinkedIn if you have questions that didn't get answered. I can try to take a look at them too.
Thanks, Graham. Thanks,
Bye
Vic.
bye.
Thanks. Bye.
See you guys.